PhD scientist. I used to work as a researcher at Sick Kids. Now I'm a medical science liaison with Alexion AstraZeneca Rare Disease. And I'm really pleased to be here and give you a winter 2024 data update from the recent congresses. And please, on Zoom, I can't really see anybody, but please interject, just interrupt me if you have any questions. So these are my learning objectives. Really, the main thing is I'm going to be discussing our new data as well as other data really coming from the 2024 congresses and learnings from clinical trials registries, real world evidence, and PNH. So really just kind of I know you're all experts, but just to kind of ground everybody, PNH is an acquired clonal hematopoietic stem cell disorder. The mechanism of the disease most commonly comes from a mutation of the PIG-A gene in hematopoietic stem cells. And this gene PIG-A, it's essential for the synthesis of GPI-linked complement regulators. And in the absence of these proteins, this renders the red blood cells as well as any other cells that are derived from that hematopoietic stem cell affected from a PNH clone, they're vulnerable to complement-mediated attack. So as you can see here, in a normal condition, the gene would be transcribed to yield a GPI anchor, which would be displayed on the surface of arising progeny from hematopoietic stem cells. In a PNH mutated gene, this gives a mutated GPI anchor such that these very important complement regulators are absent from that cell. And in the context of bone marrow failure, especially in aplastic anemia or myelodysplastic syndromes, mutations in the PEG-A gene provide a selective advantage, and this can result in the growth of a PNH clone in tandem with another bone marrow failure condition. And these clonal populations of hematopoietic stem cells will give rise to all other blood and immune cells, platelets, monocytes, granulocytes, lymphocytes. And unlike in acute myeloid leukemia or chronic myelogenous leukemia, in which the mutant clone expands unless anti-leukemic therapy is initiated, the extent to which a PNH clone expands varies greatly among patients. So it's very different among PNH patients. And how this translates clinically can be seen here in this diagram. Mutations in a PIG-A gene in hematopoietic stem cells will prevent the production of GPI anchors. And this clonal population of cells will give rise to red blood cells, really lacking those vital complement regulatory proteins, CD55 and CD59. And without these protector proteins, these cells are vulnerable to attack by terminal complement activation, that C5 beta 9, that membrane attack complex that punctures a hole in these red blood cells. And this causes intravascular hemolysis that is associated with thrombosis, organ damage, and death. And platelets are also susceptible to activation by complement, and this creates a positive feedback loop resulting in more thrombosis and clotting. And this is what really leads to those life-threatening consequences of PNH, that hemolysis, nitric oxide depletion, vasocontraction, and organ damage. And so there are three major pathways in complement that can activate the terminal portion of complement. Classical, really by that classical pathway, the immune complexes, recognition of infection, the lectin, which is activated directly by pathogenic surfaces, and then the alternative complement pathway, which is always on. It's constitutively active via that spontaneous hydrolysis or tickover. And it's the alternative complement pathway that's really dysregulated and kind of the culprit for PNH. So PNH red blood cells lack both CD55 and CD59, and I'll describe the consequences of no CD55 later in this talk, but it's without the GPI anchored protein CD55 that renders blood cells vulnerable to the MAC attack, leading to these consequences seen in PNH patients. And in PNH, most of the toxicity results from the MAC attack on red blood cells, and this can be seen from this electron micrograph of a PNH erythrocyte, this poor guy on the left. You can see it's punctured several holes. That's really from the MAC attack. But because all hematopoietic stem cells and progenitor cells lack GPI anchors, they're also vulnerable to the MAC attack. So this may not cause every cell to lyse, but it does trigger damage and inflammation in many other cells types. So you can see here this endothelial cell is really damaged by complement attack in a PNH patient. So complement activation, the MAC attack will lead to hemolysis of red blood cells and the release of free hemoglobin and nitric oxide. Release of free hemoglobin, and that will scavenge nitric oxide. And as you know, nitric oxide is a really important vasodilator, and without nitric oxide, there's vasoconstriction. And in addition, even though platelets are not lysed by the MAC attack, they're going to it's going to cause platelet aggregation and thrombus formation. And when there's already vasoconstriction from nitric oxide scavenging, this really increases the risk of thromboembolism. So you're further adding on to that prothrombotic state. And furthermore, the MAC is going to really activate leukocytes, leading to more inflammation within the blood vessel wall. You'll get neutrophil activation, cytokines, netosis, and this really increases the risk of thrombosis and also leads to these progressive causes of morbidity and premature mortality listed here. So this process is further illustrated in this diagram. Here we can see the consequences of uncontrolled complement activation in PNH, free hemoglobin, platelet, and leukocyte activation, all of this really leading to a prothrombotic state. And thrombosis in PNH can occur at any site, but the most common sites really include that intra-abdominal and cerebral veins. And 1/5 of PNH cases have thrombosis in multiple sites. Budd-Chiari syndrome is one of the most common sites of thrombosis and affects up to 25% of PNH patients, and this can lead to hepatic failure. Deep vein thrombosis in the lower limbs occurs in 1/3 of PNH patients, and arterial thrombosis is also a manifestation of PNH and present in approximately half of the reports of stroke associated with PNH. And these thromboses frequently involve both the cerebral and coronary arteries. But importantly, if your patient with PNH does present with a clot, treatment with a C5 inhibitor doesn't change your anticoagulant management. So you're still going to provide those anticoagulants to manage the clot if you choose to treat with a C5 inhibitor in your PNH patients. And this hollow man here is really illustrating the frequency of signs and symptoms in patients with PNH. You can see that despite the name of the disease, not all patients present with hemoglobinuria. Really, only about 62% of them do, despite the name of the disease. But the majority of patients are going to present with anemia and fatigue. So the most common cause of death in PNH is thrombosis, and this occurs at multiple sites, really listed here. Thromboembolism accounts for 29 to 67% of PNH deaths. And due to the microvasculature of the kidneys are also extremely vulnerable to the prothrombotic state of PNH, and up to 64% of patients with PNH experience CKD. Occasionally, it's even a nephrologist who identifies a PNH patient because they present with CKD. But nearly half of all PNH patients also have pulmonary hypertension, and this is associated with dyspnea and cardiac dysfunction. So luckily, we do have some biomarkers for PNH. Looking at these biomarkers, this study is from a national Korean registry, recent data from 2024, looking at adults naive to complement inhibitors treatment. So these patients have not been treated with a complement inhibitor. And the authors performed an analysis of patients to assess important risk factors, specifically LDH and hemoglobin in predicting thromboembolism. And also predicting impaired renal function and death in complement inhibitor naive patients with PNH. So as you can see here, high LDH above 1.5 times the upper limit of normal in red, compared with less than that in blue. You can see here that LDH above 1.5 times the upper limit of normal were associated with a higher risk of thromboembolism, death, as well as abdominal pain and hemoglobinuria in complement inhibitor naive patients with PNH. And when patients were stratified according to hemoglobin of less or greater than 8, we can see the same correlation is not there as with patients with LDH levels above 1.5 times the upper limit of normal. And given these data, a very important treatment goal with PNH is controlling LDH levels. So early diagnosis is essential for positive clinical outcomes for PNH patients. Therefore, I'd like to review the criteria by the International Clinical Cytometry Society for consensus guidelines for detection of PNH via flow cytometry. And this slide really reviews circumstances in which a healthcare provider like yourself may consider PNH testing for, using high sensitivity flow cytometry, and that's just performed on peripheral blood. And these clinical indications warrant PNH flow cytometry. So when there's hemolysis, high LDH, low hapto, high retics or high bili. Also, any bone marrow dysfunction, aplastic anemia. We know that about 50% of patients with aplastic, or sorry, 44.9, also have a comorbidity of PNH, or it's it's 44.9% of patients with PNH have aplastic anemia. And that's because we don't know why, but something about that bone marrow failure condition really promotes the growth of a PNH clone. And it's really when there's hemolysis, bone marrow dysfunction, or unexplained thrombosis that really warrants clinical indication for PNH testing. And comprehensive and routine assessment is essential to identify patients with PNH at the risk of comorbidities and premature mortality. So, any patient with indicators of hemolysis LDH above 1.5 times the upper limit of normal, or any of these one or more of these clinical symptoms listed here, is at high risk for thromboembolism. In addition, there are other key indicators here that really warrant a routine clinical assessment using flow cytometry just on that peripheral blood. So other signs of hemolysis, thrombosis, CKD, pulmonary hypertension, and also looking at the changes in the clone size via flow cytometry. So, if PNH is diagnosed, these patients should be tested once every 6 months for 2 years, and then once annually once parameters are stable. And patients previously diagnosed with PNH that are stable should be tested annually, but increase the frequency if there's any change, especially to their clone size or LDH. And patients with a bone marrow dysfunction should be tested annually if no PNH clone is detected, and then every 6 months if there is a clone found. And the PNH network really suggests that newly diagnosed PNH patients in Canada be referred to a Canadian PNH network site for initial consultation to continue workup, to discuss treatment options, and possibly enroll in a clinical trial and other research opportunities. There is a push for PNH patients to be co-managed with a PNH network specialist and their community physician as well. So usually there is co-management, but it is recommended that at least once a year a PNH patient does go to a member of a of the PNH network, really for that initial workup and consultation. So now I'd like to discuss treatment options for PNH patients. So I know that you're all familiar with eculizumab. It's a C5 inhibitor, which through the Triumph and Shepherd studies really demonstrated the ability to block terminal complement and inhibits the formation of C5a to C5 beta 9, that MAC. And that's what stops intravascular hemolysis in PNH patients. And so while these results were absolutely transformative for patients and allowed patients to kind of live with their disease rather than die from it, we did see some unmet medical needs. And firstly, really being is that infusion burden is quite high with eculizumab. Patients require an infusion every 2 weeks. And while this keeps them alive and for the most part symptom free, this also meant that patients can't really travel or take that dream vacation. Secondly, eculizumab is a set dose, and patients would sometimes, not often, but sometimes they could get breakthrough hemolysis towards when they next needed a next infusion. So here I'm showing you pharmacokinetic data for C5 in this graph. Patients, when they need that next infusion, they start to have those C5 levels creep up and that above that detectable limit of zero point 0.5 micrograms per mil, and that could occasionally result in breakthrough hemolysis. So for this reason, we wanted to create a more potent medicine that was longer lasting, so the frequency of infusion can be reduced and also result in less breakthrough. So, of course, there is a black box warning by inhibiting complement with eculizumab or ravulizumab. Patients do have an increased infection to Neisseria meningitidis. So, patients who initiate ravulizumab treatment less than 2 weeks after receiving a meningococcal vaccine, they must receive treatment with appropriate prophylactic antibiotics until 2 weeks after vaccination. So, it's vaccines against serogroup A, C, Y, W135 and B are recommended in preventing the commonly pathogenic meningococcal serogroups. So this diagram is just showing the differences between eculizumab and ravulizumab. So pretend that this is eculizumab here on the left. So eculizumab would bind serum-free C5, be internalized into the endosome, and then fuse with the lysosome where both the eculizumab molecule and the C5 is degraded. So ravulizumab has a couple amino acid modifications at the C5 binding site. It's actually quite a cool feature of engineering, such that once the RAV binds the serum-free C5 and goes into the endosome, at that acidic endosomal pH, the RAV is going to disassociate from C5 and gain affinity for the FcRn receptor, which will allow for antibody recycling, and that leads to the much longer half-life of ravulizumab. And the serum-free C5 will be degraded in the end when the endosome infuses with the lysosome. So this allows for a much more a much longer half-life, and that really means clinically that patients only require an infusion every 8 weeks instead of every 2 weeks. So I'm just going to briefly go over the phase 3 trials of ravulizumab. So this first one was designed in complement inhibitor naive patients and designed for non-inferiority to eculizumab, 20% non-inferiority margin. Primary endpoints were proportion of patients with LDH normalization and transfusion avoidance. Patients were stratified into 6 groups based on their infusion history as well, and patients were also stratified by LDH, so either 1.5 to 3 times the upper limit of normal, less than 1.5, or greater than 3 times the upper limit of normal. Enrollment of patients without a history of transfusions were capped at 20%, just to make sure that we do include a good proportion of patients that do require transfusions. And I also want to point out that in these trials, we did allow patients with other causes of bone marrow failures in this trial. So patients could have a comorbidity such as aplastic anemia or myelodysplastic. So I'm pleased to tell you that ravulizumab did meet the primary objective of non-inferiority to eculizumab for the co-primary endpoints of transfusion avoidance and LDH normalization. And looking at the patient populations, 73.6% of patients on ravu versus 66 in ecu achieved transfusion avoidance. And then for LDH normalization, 53% of ravu patients achieved LDH normalization versus 49.4 on ecu. And ravulizumab met all of its key secondary endpoints for this study. So LDH percentage change, FACIT-fatigue, breakthrough hemolysis, and hemoglobin stabilization. So because we met non-inferiority, we did test for superiority, starting with breakthrough hemolysis. And though we did not get statistical significance, we did get a p-value of 0.06. And this is clinically relevant because patients with breakthrough, the proportion of patients with breakthrough hemolysis was over 2.5 times higher in the eculizumab group versus the ravulizumab group. And this nominal difference in breakthrough hemolysis was likely due to this pharmacokinetic data. So this is the eculizumab data that I showed you before. So you can see that there is spikes in serum free C5 that could lead to IVH towards when a patient needed a next infusion, versus in the ravulizumab arm, the complement inhibition is really complete and sustained. And this threshold was not consistently met in patients receiving eculizumab. So looking at the safety and clinical manifestations of PNH, we can see the safety and tolerability of ravulizumab and eculizumab are quite similar. And the clinical manifestations of PNH, being fatigue, abdominal pain, they're improved really with the addition of either complement inhibitor. And the most frequently reported adverse effect was headache, but importantly, there were no meningococcal infections or treatment discontinuations due to adverse effects which occurred in the study on ravulizumab. So looking now at the switch study, so this is study 302. This looked at adult patients with PNH that had been previously stabilized with eculizumab. So this study enrolled 195 adults given either, they were given on-labeled eculizumab, which is 900 milligrams every 2 weeks for 6 months, and then they were randomly assigned to switch to RAV or continue their treatment on eculizumab. So I'm pleased here to tell you that ravulizumab did achieve non-inferiority to eculizumab on all the primary and key secondary endpoints listed here as well. Importantly, breakthrough hemolysis, we saw 0 breakthrough hemolysis events on ravulizumab, and we saw 5 in the eculizumab group. And the safety and tolerability of ravulizumab was similar to eculizumab. Again, the most common adverse effect being headache. And there were no meningococcal infections or deaths in either treatment group of this study. And in addition, we also have these data from our 301 and 302 trials, so the naive to complement inhibitors and the switching from ecu to ravu. We looked at this over 6 years, so this is our long-term data in our open label extension period. So we can see that in both arms, so rav being in red and then the blue being ecu to rav. We can see in both arms, ravulizumab and eculizumab were able to sustain that LDH below 1.5 times the upper limit of normal. And this is sustained throughout the entire duration of the 6-year open label extension period. And as we know from that Korean registry study, it's LDH being above 1.5 times the upper limit of normal that really increases the risk of thromboembolism, organ damage, and death in PNH patients. So really having that sustained control of LDH with either complement inhibitor. So here, this is data presented at ASH. So this is a real-world evidence study presented looking at an Italian cohort of patients, and this evaluated the safety and tolerability of PNH patients that switched from eculizumab to ravulizumab. So the primary endpoint was the mean percentage change in LDH from baseline, and the authors saw a mean decrease of 2.7% in LDH upon patients switching from ecu to rav. Importantly, the authors also looked at breakthrough hemolysis. In the eculizumab group, there were 5 breakthrough hemolysis events, and 80% of these correlated without happened without a correlated medical condition. In the ravulizumab group, there were 2 breakthrough hemolysis events, and both were correlated with a complement amplifying medical condition, one being gastroenteritis, one being infection. So this study showcases how that complete and sustained terminal complement inhibition with ravulizumab really leads to better control of the disease, as the breakthrough hemolysis events were not due to lack of serum free C5 inhibition, but really due to these complement amplifying conditions. And the same cannot be said for the eculizumab group. And this study also looked at transfusion requirements. So of those patients that remain transfusion dependent, 25% of them in the eculizumab group versus 20 in the ravulizumab group. There were the transfusion dependent patients in the eculizumab group actually required more units of blood than in the ravulizumab arm. And so here I'm showing you another study that was released in late 2024. So this is a patient-reported outcome study really done in the United States. So the study's kind of cool. Patients were given a Fitbit. So these ravulizumab patients were given a Fitbit to really, and also had a series of comprehensive interviews to assess their quality of life, along with filling out FACIT-Fatigue. And for every one PNH patient on a Fitbit, the authors investigated 3 people from the general population wearing a Fitbit. And it was found that patients with PNH on ravulizumab had patient-reported outcome scores within the normal range for the US general population. So here are some key takeaways of the study. So really, ravulizumab was found to be non-inferior to ecu for all the primary endpoints tested. In the naive complement inhibitor study 301, the primary endpoint was transfusion avoidance as well as hemolysis. And then in the switch study, we looked at hemolysis. And the clinical significance of this is really showing that pharmacokinetic data, ravulizumab it's not just a longer acting complement inhibitor, it's more potent. It has a complete and immediate sustained C5 inhibition. Patients can safely start RAV or switch from ecu to RAV, and this also reduces that treatment burden. Patients now don't need an infusion every 2 weeks. They can go every 8 weeks. So one of the asks from clinicians really was data for ravulizumab in pregnancy. And so this was a small study released at ASH that I'm excited to get into. So currently, the standard of care for PNH patients is to switch them back to eculizumab. If they're on ravulizumab, switch them back to eculizumab for the duration of their family planning and pregnancy. But as for the standard of care the standard of care for non-pregnant patients with PNH is increasingly becoming ravulizumab. The question really arises is if this molecule is safe during pregnancy. And prior to this publication, there was limited data, but it's of course important to counsel your patient to see really what is best for them. So this was a retrospective case series, which included 12 pregnancies and 5 women with PNH. And this included, this included 6 pregnancies with eculizumab and 6 pregnancies with ravulizumab among 5 women with PNH. So looking at the eculizumab pregnancies, there were 2 miscarriages, unfortunately, in the 7th and 8th week of pregnancy, and another pregnancy was terminated at 25 weeks gestation, and that was really due to persistent intravascular hemolysis, fetal growth retardation, and inadequate blood supply to the fetus. There were 3 surviving children from the 6 eculizumab pregnancies, and they showed normal development at the last follow-up. In the 6 ravulizumab pregnancies, 6 healthy children were born. One was born prematurely at 35 weeks, and 4 women were breastfeeding after these 6 ravulizumab pregnancies. Importantly, escalation of C5 inhibition was required in 3 out of 6 eculizumab pregnancies and 3 out of 6 ravulizumab pregnancies. And regardless of the C5 inhibition type, prophylactic heparin was routinely administered once there was pregnancy detected. So the choice of these women to remain on ravulizumab during pregnancy was really due to complications during their pregnancies on eculizumab. And this was also supported by control of intravascular hemolysis, despite pregnancy really being a very complement activating condition. And it's important, again, to really counsel your patient, and all treatment decisions were made after intensive patient counseling, really at the risk of maternal and fetal PNH complications, the evidence of eculizumab during pregnancy, and the lack of experience with RAV during pregnancy. But this study was the first to report a series of 5 PNH patients with ravulizumab exposure throughout 6 pregnancies. And although this is a retrospective study, so this doesn't really allow for direct comparison, it is noteworthy that 6 out of 6 ravulizumab pregnancies resulted in the birth of healthy children with normal development to date, and there were premature termination of a fetus in the eculizumab pregnancy due to intravascular hemolysis. So ravulizumab may be a safe option for PNH patients that want to plan families, but more data is definitely needed. So now I'm going to discuss a new molecule, danicopan, for patients with clinically significant extravascular hemolysis and PNH. So there can be multiple causes of anemia in PNH, with extravascular hemolysis just being one of them. We know that these patients often have aplastic anemia. Some patients have myelodysplastic syndrome, but there can be extravascular hemolysis that it can be a residual cause of anemia in PNH. And this slide is really just to remind you that PNH red blood cells, they lack CD55 and CD59. So those are the important complement regulators that are absent on PNH red blood cells. So CD59 protects against the MAC formation that is responsible for intravascular hemolysis, and CD55 protects the red blood cell from proximal complement opsonization. And since these PNH patients lack CD55, their red blood cells are opsonized by C3b fragments, which really signals to macrophages in the liver and spleen to eat me, leading to EVH. And this is a controlled process and does not lead to thrombosis, organ damage, and death like in IVH, but this can lead to residual anemia and even transfusion dependence. And approximately 10 to 20% of patients with PNH experience signs and symptoms of clinically significant extravascular hemolysis, where that really impacts their quality of life. So danicopan is an oral factor D inhibitor, which targets at the most proximal part of the alternative complement pathway. So it's a factor D inhibitor, and that's the very top of the alternative complement pathway. And that's going to block the formation of C3b, preventing extravascular hemolysis in PNH patients. So that's going to stop that tagging of red blood cells and stop that eat me signal on macrophages in the liver and spleen. And this therapy is designed to be taken in conjunction with eculizumab or ravulizumab. So patients have that backbone of a C5 inhibitor therapy to protect them from the deadly consequences of intravascular hemolysis. And then danicopan is going to address the quality of life aspects that are really a result of extravascular hemolysis. So Alpha is an ongoing phase 3 study. It's a superiority study to assess safety and efficacy of danicopan versus placebo as an add-on therapy for patients with PNH with clinically significant extravascular hemolysis on C5 inhibitors. And so the data I'm going to be presenting you today is fresh out of ASH. So it's our long-term data from ASH. So another black box warning: because we are inhibiting higher up in the complement chain, patients must not only be vaccinated for Neisseria meningitidis, they need to be vaccinated against Streptococcus pneumoniae as well. And although it's not in the black box warning, it is recommended to vaccinate against Haemophilus influenzae. So the methods of the alpha study: so patients were randomized 2 to 1 to receive danicopan versus placebo. The initial evaluation period was 12 weeks, and now we're in the 2-year long-term extension. So key inclusion criteria is adult patients with clinically significant extravascular hemolysis, and we defined this as hemoglobin less than 9.5 and retics of greater than 120, and patients also had to be stable on a C5 inhibitor. We looked at changes in baseline hemoglobin, absolute reticulocyte count, and LDH, hemoglobin increase of greater than 2 grams per deciliter, as well as transfusion avoidance. Danicopan is an oral factor D inhibitor, so it's taken 3 times a day, and there was dose escalation permitted based on the clinical response. And of course, we collected safety and tolerability data. So just looking here at the patient disposition, there were looking at, we can see here patients did have low hemoglobin, although I don't know if this would be enough to warrant a transfusion in your center. But importantly, we also saw there is a little higher LDH in the dinicopan to dinicopan arm. But importantly, all patients did have that criteria of clinically significant extravascular hemolysis. So low hemoglobin and retics greater than 120. So here I'm showing you our long-term data, our 72-week extension. So here we can see the dinicopan arm in the dark blue, placebo in the green, and then upon their transition to dinicopan, it becomes light blue. So you can see there's minimal changes in hemoglobin from baseline to week 12 in the patients receiving placebo, but that improved after week 12 once they transitioned to dinicopan. Both arms are quite similar by week 14, and they were maintained up to week 72. So that increase, that stat sig difference in hemoglobin was seen. So while there's no improvement in the proportion of participants achieving transfusion avoidance with at week 12 with the placebo. So we can see with danicopan, there is a stat sig difference between those patients receiving placebo versus danicopan for transfusion avoidance. Once those patients on placebo do switch to danicopan, they reach that same proportion of patients that were initially on danicopan in terms of transfusion avoidance. And additionally, I think it's important to note that of the patients, so about 20% of patients did not achieve transfusion avoidance. Of those patients that didn't meet transfusion avoidance, that mean number of RBC units transfused did decrease once they started treatment with danicopan. And that's similar results to what we saw once patients transitioned to RAV in that Italian real-world evidence study. But 80% of patients in both arms maintained transfusion avoidance at week 72. So importantly, looking at the maintenance of intravascular hemolysis blockade, importantly, mean LDH levels remain well controlled, as you can see from both arms, remain well below that 1.5 times the upper limit of normal, which, as we know from that registry data, is the main predictor of thrombosis, organ damage, and death. And there is a nominal decrease once patients do transition to danicopan. Clinically meaningful improvements in facet fatigue were seen once patients transition to danicopan. So we can see here actual scores did remain a little lower in the placebo to danicopan arm than in the danicopan to danicopan arm at week 12, but they became about similar at week 16 and pretty much maintained in the long-term extension. So improvements in absolute reticulocyte counts were also observed from baseline to week 12 and maintained in the danicopan to danicopan arm. So in the placebo arm, changes from baseline to week 12, very minimal, but then improved after transitioning to danicopan. And the absolute reticulocyte values become comparable across treatment arms, really by about week 13 after initiating danicopan, and then this was maintained throughout up until week 72. So importantly, no meningococcal infections were seen during the study. There were some liver enzyme elevations, so it's really important to monitor patients, especially those that have hepatic disease, for liver enzyme elevations on danicopan. And here are the most common treatment emergent adverse effects. Here I'm just showing you all of them. Obviously, the most common really being headache and pyrexia, but quite aligned to what we already see for patients on eculizumab or ravulizumab. So here I want to talk about danicopan plus RAV or eculizumab really being what clinicians are calling a belt and suspenders approach to PNH. So this publication just came out really calling this dual therapy approach that belt and suspenders kind of safety net. While doing dual inhibition, so the C5 inhibition is going to target the MAC, which is going to protect patients against IVH. There are other emerging upstream complement inhibitors in PNH that target their monotherapies, and they target complement inhibitors upstream. So targets really include pegcetacoplan, which is a complement factor C3 inhibitor. There's also a factor B inhibitor, iptacopan, and then the factor D inhibitor, danicopan. So just noting here, crovalimab is a C5 inhibitor. It is not Health Canada approved, and danicopan is not a monotherapy. It's designed to be taken with a C5 inhibitor, mainly eculizumab or ravulizumab. So these proximal inhibitor monotherapies, mainly pegcetacoplan and iptacopan, they target upstream of C5 in the alternative complement pathway. Iptacopan targets very upstream, just solely in the alternative complement pathway. But none of them inhibit directly the classical pathway or the lectin pathway either. And it's also important to note that a lot of these complement inhibitors, they have very short half-lives that are really only hours to days. And the authors note that a strong classical pathway stimulus, such as infections, trauma, surgery, this can lead to massive breakthrough intravascular hemolysis on patients with alternative monotherapy complement inhibitors. And this is just showing that danicopan data changes in baseline hemoglobin, which you saw earlier. But yeah, it's really important to note that there are strong classical pathway stimuli, such as infections and surgery, and this can lead to massive breakthrough hemolysis on a monotherapy that's just targeting proximal alternative complement. And this is really illustrated very well in this figure. So this is from a publication that came out. This came out in 2022. So if a breakthrough hemolysis event happens on a C5 inhibitor, this is less severe because only one membrane attack complex is formed per molecule that escapes eculizumab or ravulizumab. In contrast, incomplete inhibition with an alternative complement inhibitor monotherapy, this is going to catalyze the cleavage of multiple C5 molecules, amplifying the breakthrough. As you can see here, incomplete C3 inhibition is going to catalyze the production of multiple MACs, and this can really lead to very acute and very traumatic breakthrough hemolysis. That's why the authors discuss the potential advantage of a dual therapy, mainly eculizumab or ravulizumab plus danicopan, compared with the proximal inhibitor monotherapy. But real-world data is still needed to confirm this. Lost pills, food poisoning, infection, viral gastroenteritis, those are real-world events that are underrepresented in clinical trials in these standalone complement inhibitors. So what is the contingency plan for managing these events, especially when a patient travels? Will this lead to more breakthrough hemolysis? And this is why we need more real-world data, especially as clinicians are gaining this menu of therapeutic options for their rare disease patients. So with that, I realize that I am ahead of time, and